All right, good afternoon, everybody. It's like a pretty good crowd already, so maybe we'll get started. Let me just silence this. See if that's even possible. Okay. All right, so thanks a lot for coming to the Mirror Grand Rounds. Today, I'm going to give the talk, and I've been thinking a lot about research support, given the political climate and the recent cuts to NIH and ARPA and other agencies. So I thought I would talk about how we built a research program around intracerebral hemorrhage here at Mount Sinai, and tell the story of the origin of that and how we're hoping to sort of weather this funding storm over the next year or even longer. We haven't been directly affected by anything yet, but just anticipating that there might be cuts in the future in some of the projects we're involved in. And so maybe this is a pertinent topic to those of us on the line, and we'll kind of focus more on the research side than on the clinical side for this talk. You know, as I mentioned, and as we've all been following, there have been a lot of cuts recently to some of the funding that supports a lot of the work around what we do in healthcare and in research related to healthcare. You know, this article is from today in the Washington Post, looking at a cut of 40% to the NIH overall, and this is from 47 billion down to 27 billion, and that's the current proposal that's being evaluated. Then, you know, we've got cuts to other organizations as well, and there's a broad ARPA cut of 12 billion, you know, that was reported on March 26th. So this will impact us in many different ways. I wanted to talk about how I got into intracerebral hemorrhage research, and so I'm going to tell the story of Dr. Mako, who is our division chief at Mount Sinai here, kind of pulling me aside when I was a fellow in endovascular at Mount Sinai after I'd completed my neurosurgery residency, and talking to me about giving me a job at Mount Sinai, which is where I've been working for the last 8 years after fellowship. So, of course, he pulled me into this pub right here in the Upper West Side near Mount Sinai West. And we were sitting down, and he told me, we want you to focus on intracerebral hemorrhage. And, you know, in 2017, intracerebral hemorrhage was not the most exciting of disease processes to focus on. And so in my training, we'd always been focusing on, you know, mastering aneurysm clipping and coiling and other complex disease processes, management of cerebral processes. So I said to him, well, what about aneurysms? And he said back to me, I can't promise anything about aneurysms. So I took that offer, you know, really seriously. And I thought, you know, maybe there is something if we really focus and create a research program around intracerebral hemorrhage. And I bought into it. And another thing he said to me that I've always remembered is he said, make other people's trash your treasure. And, you know, not to say that intracerebral hemorrhage is trash. However, it's a disease process that not a lot of focus had gone into specifically. And there had been a lot of failed trials and failed research efforts at that point. And so it was a little bit stalled. There has been a lot of progress since, and I would not say that now. I would say this is a hot topic now. But back then, it was not the hottest topic. And so this I think resonates even today for those of you who might be trainees thinking about what you're going to focus on over the next 10 years. But I think this really hit home for me, and focus on something where there's a little bit of space where you've got an opportunity to really make a difference, and fewer people might be focusing on that area than the other areas you're thinking about. Dr. Betterson was the chairman of our department and still is, and he had this idea of centralizing ICH care at one hospital within the Mount Sinai Health System. So I was going to come in and focus on intracerebral hemorrhage as a research focus and a clinical focus. And we were going to put all the ICHs in one hospital in the Mount Sinai Health System. and make it possible to concentrate the research and the clinical efforts, and then compound our learning and our systems learning around this disease process. And so I found that to be a really intriguing idea. And the Mount Sinai Health System has numerous hospitals around Manhattan and all the boroughs, and even outside of the boroughs on Long Island. And we made the decision to centralize all that care here at Mount Sinai West, which is on the Upper West Side. So we made this the focus. But then there's a flip side to that phrase that Jay said, make other people's trash your treasure. And I'm going to kind of think about that a little bit here when I talk about alternate sources of funding. And that's make other people's treasure your treasure. And people and companies are motivating research in our space, and they create devices with the goal of helping our patients. And that's their treasure. And so figuring out how to incorporate a device or further the research around a device or a software package is also a strategy that can be helpful for patients and can help to fund your research enterprise. And so I'm going to talk about collaboration with industry. I have a few pictures here, and these are the projects I'm going to talk about. A project with EROS, which is the double lumen catheter that can irrigate and drain at the same time. A subgaleal electrode with a software package for continuous EEG monitoring using implantable subgaleal electrodes for patients in the intensive care unit. And then sonolucent cranioplasty equipment where you can place it in a procedure and then you can do ultrasound at the bedside or in the office in the future. And you can see better through that cranioplasty piece or burhole cover or whatever it is. And that's a company called Longevity. So I'm going to show you some of the projects we've developed over the last few years with these companies and a few others. And so that brings me to my conflicts of interest page here. And, I like to say, and just recently started putting this on the top here. So when I'm talking about surgery, I am a surgeon, and we have created a research program around surgery for minimally invasive surgery for ICH. And so there is some bias there in performing surgery as a surgeon. And so I think that's important to list on there. Although we try to do the right thing for patients at all times, but there's this inherent bias by being a surgeon. In terms of the funding for these trials that you can see here, these are all trials and research support in which I'm not personally compensated in any way, but I'm involved in managing research that is sponsored by industry. And so I've listed all these studies here. A lot of them have to do with ICH, including this one here, the MIRROR registry, Integris funding, this registry, and also this lecture series, the MIRROR Grand Rounds. So thank you to them. But then there's also federal funding included here, such as the Evacuate trial, which is funded by the Australian government, evaluating the Surgiscope, which is the device made by Integra for the early treatment of minimally invasive, of ICH through minimally invasive ICH evacuation with that device. These trials were funded by Penumbra, and they're both complete. And then the Reassess ICH study, which I've recently had the opportunity to get involved in, which is run by Wendy Zai and Matthew Flaherty, and that's funded by the federal government here in the US. Those are the ICH-related studies. And then I'm also going to talk about some research, as I mentioned, funded by specific companies, including EROS, Longevity, and ICE Neurosystems. And then other things that I do have financial interest in, I'm going to try to avoid talking, but I am going to mention this one, Borealis, and I'll make note of my conflict, my personal conflict there when I talk about that. So the last 10 years have been very eventful for minimally invasive ICH evacuation, or rather last 20 years. And these are really the three pieces of information that we get from those major steps forward we took at each of those, the publication moments of each of these major trials. And if you're familiar with the space, you recognize this graph right here from STICH 1, published in 2005. And that showed that there was no survival difference between patients who underwent early surgery, early not being early like we think of it now, but early being within 48 hours, and initial conservative management. So negative trial for craniotomy. And then MISTI in 2019, showing also a negative trial, but showing this relationship between the amount of clot that we remove and the probability of a good outcome. So some major understanding about the physiology of intracerebral hemorrhage and what the potential impact of removing the blood clot is, and seeing that interaction between the amount of blood there and how the patient does long-term was really critical to motivate the next generation of studies, and continues to be really a core piece of information that we have. Then more recently last year, publication of the ENRICH trial. And this is a trial that looked at deep hemorrhages. Anterior basal ganglia is the abbreviation here. Really deep hemorrhages, not including thalamic, and lobar hemorrhages. And that trial showed an overall benefit. However, it appeared that the benefit was specific to the lobar hemorrhages, and the basal ganglia hemorrhages pretty much straddled the neutral minimal treatment effect, or no conclusive treatment effect for that group. No conclusive harm, but no conclusive treatment effect for this subgroup analysis looking specifically at the basal ganglia hemorrhages. So when I look at this information, I think about how we took major steps forward. Each one of these was a big step, but little steps had to occur along the way to develop the MISTI protocol, to develop the endoscopic, the endoport mediated evacuation technique, and all these other little publications that came along that led to these major steps forward. And so I'm just sort of justifying that there's real value in doing these smaller projects and making incremental improvements in the procedure and the way we care for these patients, so that we can continue moving the ball forward, but between these major studies. And that's really what the purpose of this lecture series is to get people, everyone in this call, together to continue the conversation between the major steps forward. There are future major steps forward already occurring. There's the evacuate trial, as I mentioned, that's approximately halfway through being enrolled, and that's an early evacuation surgiscopic trial. Then there's the Dutch intracerebral hemorrhage surgery trial, which is also well into enrollment in the Netherlands, and that is a early evacuation endoscopic trial where evacuation has to occur within 8 hours. So we will hear about those trials and get those results in the future, and I'm sure they will provide us with critical information. We also have trials in the planning stages that also evaluate early evacuation with various devices. This is the REACH trial, which has been funded and will start in the near future. This is going to be run with the same group that ran the ENRICH trial with Gustavo Perdilla, Dr. Dan Barrow, and others from Emory, and using the endoport. But you can see that the time period is moved down to 12 from 24 based on their subgroup analyses from ENRICH. They recognized that it appeared that deep hemorrhages were more likely to benefit when the evacuation was done earlier, and they may even have a different surgical target looking at achieving more effective evacuation down to approximately 6 cc's is what I understand. And then a possible NIH-funded trial in the evaluation phase right now with the NIH, with Jay Mako and Magdi Salim and others as the PIs of this trial. If this is funded, this will be a comparison between less than 8 hours and 8 to 16 hours versus medical management. So there are two subgroups in the treatment arm, and we'll get some information about the value of time with this trial as well. So I'm going to talk about specifically about mechanisms of research funding. And federal funding, has been the mainstay for many of us for many, many years. With no question, there are the study sessions, 3 times a year, you have your submission dates, you hit those, and it's as reliable, as anything, but that does appear to be changing. And so I'm going to also talk about how you can build a research program around industry funding, philanthropy funding, and then perhaps even internal funding. I'll give you examples of each of those projects. So here we've got the projects I'm going to talk about with industry funding. The TUSC trial, I'll start with that. And I was thinking about, and we were all thinking about, what are the problems with minimally invasive ICH evacuation? One of the problems with surgery for ICH in general is that rebleeding can occur, especially when you do the evacuation in the early window. And if that does occur, first of all, you want to avoid that. But if it does occur, you want to recognize it and treat it immediately. Sometimes it occurs asymptomatically. And what we saw that with the MISTI trial, that in the trial, there was a 32% asymptomatic brain bleed rate. So a fairly high asymptomatic rate, a very low symptomatic rate. And we were thinking about what's a way to recognize this other than doing a CAT scan every single day for every patient. And perhaps you leave a sonolucent cranioplasty at the end of the procedure, and you can ultrasound the patient every day, which is a low cost way to see in the skull. And so here are some pictures from the company's website showing it's both clear to the eye and it's also clear to ultrasound from the PEEK material variant that it's made from. And here's the burr hole cover that I've been using in our procedures, and that we've been running a registry to evaluate its diagnostic ability for us to see through it with an ultrasound. And so here are some of the inclusion and exclusion criteria for the study that we put together. It's funded by Longevity. And the primary outcome is looking at the volume of ICH that we can see through the ultrasound and looking at it on CT. So whenever we do a CT, we try to do an ultrasound around the same time. And then we have some secondary outcome measures there. So here's one example. I'll show you what this kind of looks like. Here's a patient with a right parietal ICH who underwent endoscopic evacuation. You can see there's minimal blood left there. I left this 2 centimeter sonolucent burr hole cover. And here's the patient coming in the office. Here's what it looks like in the OR. Placing the burr hole cover is the same size as a regular burr hole cover at 2 centimeters. And then in the office, I was able to get this picture looking through the burr hole cover so I can see the cavity. I can see the ventricle over here. And I can see some edema around where the cavity is. This is not as hyperechoic as blood, so I can tell that this is kind of some edematous brain rather than hemorrhage. When you use this, there are some subtle nuances because you're going to be ultrasounding through it, and because you want to have to fit this burr hole cover there, you have to pre-size the hole. So it completely recesses in the hole, so you have to pre-size the hole, make the hole exactly 2 centimeters. So that's a little bit different than your usual strategy of making whatever hole you make and then putting the burr hole cover on top of it. You have to, I'll show you some other changes in the future in the next slide. Here's another example. This is a right frontal basal ganglia ICH. You can see sort of more of a partial evacuation with a little bit left here, 20 cc's left there. And then here's the image, and you can see here the path and some blood here. The larger area of blood right there. And you can see some blood along the side there. And you can see the ventricles here. So this is on post-op day 1 in the ICU. Some other nuances are that you can use these things in the procedure, but you have to wash them out because they're sono-opaque, such as Surgiflow and gel foam. You also have to close with sutures instead of staples if you would normally do staples to make sure that you can still ultrasound. And you have to be very sterile post-op when you're evaluating and pushing on the recently closed wound. So a few subtle nuances there. You can also use, as we have, the cranioplasty for a larger ICH treatment, not a minimally invasive ICH. And so here's one example of an AVM that ruptured. I did a hemicraniectomy, and then 3 months later did an AVM resection with placement of the cranioplasty in the same procedure. And then I was able to get some in-office pictures of the intracranial space and see that no hydra is developed. There are no other issues here. So that could be done in replacement instead of a CT. Moving on, another project related to a company called EROS has been the DIVE study. And this is where we're looking at catheter drainage of intraventricular hemorrhage. Intraventricular hemorrhage has plagued us for decades. And we haven't seen a positive trial in this particular disease process. And we know that this is a major factor in the severity of an ICH. 40% of the ICHs that we treat have intraventricular hemorrhage with spontaneous intracerebral hemorrhage. And it is a major predictor of poor outcome in those patients. The CLEAR 3 trial was negative overall, but showed that there was a correlation, just like in MISTI 3, with the amount of blood that was removed and how the patients did long-term. The current technology, including external ventricular drains, such as these here, or you could even try to do an endoscopic evacuation if you have IVH, or you can, of course, medically manage IVH. But all of these techniques have their own problems. The EVDs frequently become clogged. When you manipulate the EVD and it becomes clogged, that's an infection risk. Often you the device, and then there might be a need to place a bilateral EVD if there's an EVD malfunction. So we looked at our own EVDs and saw that in our own EVDs, there was a very high rate of complications over a year prior to considering bringing in this new device and evaluating it. We saw that there were tract hemorrhages in 13%. There was some form of manipulation in 17%, with revision in another 17%. And so we felt that this prolonged patient's ICU care, and was a factor that correlated with poor outcome for patients because of the complications related to EVDs. And so it felt like there was really a space to evaluate this new device that is an irrigating catheter, and so proposed to perform a prospective study funded by ERAS, which they did, and I'll show you a few patient examples from this ongoing study. So here's one of our first cases. This is a middle-aged male with a right thalamic hemorrhage with intraventricular extension. The patient came over. Here's how this is placed. Here's Trevor Hardigan placing it. So we place this in the angio suite and use stereotactic navigation. Here's the device itself. It's got 2 ports, as you can see, because it's a double lumen. And what's interesting about it, so you flush both ports, is that you have to put in this passer and you have to reverse pass it. So you put in the passer and then you reverse pass it because it's got this double lumen connection back here that can't be passed. So that's why you have to go from distal to proximal, which is different than how we do normal EVDs. And then here's the placement of the catheter. And once it's placed, you can confirm that it's in cerebrospinal fluid and then pull out the slack and then suture it in. So a little bit of a nuanced placement, but not very challenging, not very unusual. Here's what the final picture looks like, and there's the final picture with the incision. Here's how this patient's scans looked. This is the initial image, and then we put 2 milligrams in 1 liter of LR, and then irrigated that in continuously. So this is continuous TPA irrigation at a very low dose. And then 24 hours later, after continuous TPA, we had completely cleaned out the ventricle there. So you can see that sort of an impressive, rapid evacuation of the blood. And similar with this patient, I won't go through all the details again with that patient, but you can see the caudate hemorrhage with intraventricular extension. And then after 24 hours, you can see mostly evacuated, dramatically decreased, including the intracerebral hemorrhage portion. And then after 2 days of continuous TPA, completely cleared out. So there is an ongoing study right now called the ARCH trial, which is randomizing patients to compare TPA, continuous infusion of TPA with this catheter, bolus TPA, like we normally do with an EVD with the catheter, and then bolus TPA with a catheter. So it's a 3-arm study. So looking forward to the results of the ARCH trial to compare and see, does it really matter if you're continuously irrigating? As from those cases I showed you in our experience, it does seem to be beneficial. So kind of another incremental possible improvement in how we treat these patients. Now let's talk about these last 2 here. And these are mechanisms for monitoring the brain in the post-op setting. Status epilepticus, non-convulsive status, and even seizures post-op, or in the intracerebral hemorrhage time course occur with a certain frequency. Here are some factors that predict if a patient with ICH is going to have a seizure with non-convulsive status. And here you can see the ICH score, whether or not the patient had surgery, and then almost the hematoma volume and lobar involvement. So this does happen in some patients, and we had the pleasure of interacting with this company, ICE Neurosystems, which was founded in one of the co-founders is Alan Waziri, a neurosurgeon himself, a very dynamic and engaging person who developed this with his other co-founders. And this is a system where you implant a subgaleal probe, and then there's a software package that allows you to monitor certain features. So for me as a neurosurgeon who doesn't normally read EEG, there's a lot of interpretation here that goes the extra step and puts us at the bedside and allows me to interact with it in a way that I'm not able to interact with surface EEG with the software. So we put together this study looking at electrocorticography, implanted continuous electrocorticography, electroencephalography after minimally invasive ICH evacuation. Here's what the subgaleal leads look like. So it's placed in the operating room or at the bedside, and you put them on both sides. You put one on this side, one on the other side, and you can compare those results to what we have in the past for scalp EEG. And in some cases, patients have both subgaleal and scalp. And then you get some very interesting data that's already processed and shown to you in graphical form here, such as burst suppression, the symmetry, overall symmetry of the readings, and alpha power. We put this together in an early manuscript with our first 6 patients. And you can see here some discrepancy between the alpha delta ratio on the left and right hemispheres. So some ability to detect the abnormality in the presence of the hemorrhage, and some other things that I won't scoop ourselves with that paper. And so now in the future, expanding on this continuous monitoring in the post-op setting, there's Precision Neuroscience. This is a company that is a brain-computer interface company that's developed a um, electrocorticography cortical array with a very high resolution set of electrodes with 1,024 electrodes, I believe, in one square centimeter. So perhaps even more than that. If I got that wrong, I apologize. But it's quite very high resolution corticography. And the reason for this is there is a global impact to the brain with intracerebral hemorrhage. And we see that with global widespread endothelial cell activation and blood-brain barrier leakage. We also see it with hyperacute injury markers on imaging, where you can see them far from the hemorrhage. And so the project that has not started yet, but will start in the near future, is to implant this during the procedure and to perform monitoring in the post-op setting, and to attempt to recognize when patients have more severe but perhaps unrecognized global injury related to the intracerebral hemorrhage, and to characterize that with this corticography strip. Also, perhaps to diagnose cortical spreading depolarization and non-convulsive seizures in patients where they perhaps otherwise might not have been detected with scalp EEG, or perhaps with no EEG. If the patient had had a 24-hour monitoring session, appeared clear, and then had events later, they might be missed by our normal standard of care method. Here's what the array looks like. And here's one patient who had the array placed at Mount Sinai for a tumor. And you can see here's the tumor. Here's where the array was placed next to the tumor. Here's the output of the array. And it's possible to determine what the patient's doing if they're moving which finger based on what the array output shows. And so that's what you can see for the output. This might also be helpful for prognosis. And here we've got Jan Klassen's work, and you can see that there's some ability to predict which patients are going to regain consciousness from surface EEG, and perhaps this provides some additional resolution and might also be a prognostic tool. If implanted fully, it might also be a way of monitoring a patient's recovery as they go through the complex recovery of an ICH patient. And so in the last few minutes, 2 minutes, I'm just going to mention some other studies that help to fund research in the space. And we've just gotten involved with the Reassess ICH study with Wendy Zai and Dr. Matthew Flaherty, and looking forward to enrolling in this study. This is focusing on how patients who undergo surgery or don't undergo surgery do in the long term, in their long-term recovery. So here are the inclusion criteria. And then the aims are to look at cognitive recovery and decline long-term after intracerebral hemorrhage recovery, whether they underwent an evacuation or not, to see what perhaps the impact of evacuation is on cognitive recovery. So really taking it to the next level beyond the functional recovery we've been focusing on in the trials I was showing you a few minutes ago. And then philanthropy has also played a small role. This is something where you have to sort of get lucky or not get lucky with somebody who you care for, or know, making a donation to the research project. And here's one example of a small research project we did that was funded by philanthropy, looking at neural organoids in the lab and exposing them to blood, and seeing whether those neural organoids respond to blood appropriately with appropriate inflammatory response, which they did. And then seeing if exposing them to blood for a short period of time or exposing them to blood for a longer period of time impacted the transcriptomic expression. And we were able to see that there was a significant difference between the length of blood exposure did significantly impact how the microglia and other cells reacted. And so more to come on that. And thank you to Karina and Braxton and James for the lab research for that. And then, of course, there's internal support. And this is where I do have a conflict, because this internal support has led to the development of the device and the development of a company to mobilize that device outside the institution. And so secondary inflammation is a major problem for intracerebral hemorrhage. And that's something that we haven't yet developed a good treatment for. And we, in conjunction with Biodesign, which is an internal device development group here at Mount Sinai in the neurosurgery department, came up with a focal cooling strategy and developed a focal cooling device that you implant at the time of the procedure and leave in for 48 hours after. And we've had the opportunity to do a lot of research around that over the last few years, and started doing some animal studies to evaluate the efficacy of that device. And so the purpose of this talk was really to give a sample of ways to find angles to improve the care of these patients, and also to build research that is diversified, and might be more resilient in the challenging times related to federal funding, that we now find ourselves in. So I'll stop there. Thanks so much for listening. And if anybody's got any questions, happy to chat.
Hi, everyone. Whoever is participating in the mirror trial, please join the second Zoom link to participate in the subject case review. Thanks. See y'all soon. Bye.
Thanks again. All right, we'll stop there and see everybody on the other link. Thanks very much. Bye.